Good afternoon and welcome to our webinar, Cancer and COVID-19 in Victoria. And I'm your MC for this afternoon. My name's Associate Professor Philip Parenti. I'm the Director of Cancer Services at Eastern Health, but also the Chair of the Clinical Directors Group of the VCCN Network. And again, welcome. Acknowledgement of the country. I'd like to acknowledge the traditional custodians of the land of which today's presentations are located. I'd like also to pay respect to the elders, both past and present, and to the Kulin Nation, and extend that respect to other Indigenous Australians who are present online. Today's event is brought by the Victorian COVID-19 Cancer Network, the VCCN, and the VCCN was created as a response to challenges involved with the managing of cancer care among the current global health crisis known as COVID-19. The joint initiative of the Victorian Comprehensive Cancer Network and the Monash Partners Comprehensive Cancer Consortium aims to provide support and advice to clinicians and healthcare services treating cancer patients during the COVID-19 pandemic. The Victorian COVID-19 Cancer Network collaborates on a digital platform for professional discussion, information and support as the pandemic progresses. You can join the network via the VCCC and the MPCCC websites. And as you can see, they're shown here on this slide. You can also follow us on social media like everything else. And you can follow us on Twitter, Facebook, LinkedIn. Today, if you have any questions with a Q&A, please write them and I will collate them and put them into thematic categories. So you Q&A, you raise your hand and use the chat. And then we have 15 minutes at the end of the presentation to answer the questions. And please submit these questions throughout the presentation. And today I have the pleasure of introducing our international speaker, Dr. Ziad Bakouny from the Dana-Farber Cancer Institute in Boston, USA, who's really highlighting the biological interplay between the two diseases of COVID-19 and cancer, and provide practical recommendations for the treatment of patients with cancer during the pandemic. We'll also discuss the potential legacy of the pandemic on cancer care due to its effect on cancer research. It'll also provide biological insights from the cancer research community in the United States that could help develop novel therapies for all patients with COVID-19. Ziad Bakouny is a postdoctoral research fellow at the Lank Center for GU Oncology at the Dana-Farber Cancer Institute. He's published over 45 PubMed articles in journals that are such as the JCO, Cancer Discovery, the European Urology Focus, etc. And looking forward to your presentation, Ziad. So welcome.
Thank you very much for that very kind presentation. Just got to share my screen now. Thank you very much for that introduction, Phil. That was very kind of you. It's my absolute pleasure to be speaking to you all today, and thank you very much to the Victorian Cancer and COVID Network for the invitation to speak. So I've dated this November 5th/6th because it's still actually November 5th here in the United States. I'm speaking to you from Boston, so we're a day before you here. My presentation is entitled COVID-19 and Cancer, Current Challenges and Perspectives. So these are my disclosures. These disclosures are not relevant to the content of my presentation. So first of all, I'd like to start with a brief introduction to say, why are we talking about COVID-19? I was just chatting with Phil actually just before logging on, and he was telling me how you've managed to maintain a very nice low number of COVID-19 infections in Australia, which is frankly incredibly impressive. But the rest of the world has not been so lucky. Unfortunately, here in the United States, the brunt of the effect of the pandemic has been felt across the United States, across all the states, and across the world. Really, there's been 15 million cases. This is data just pulled today from the New York Times, with more than 1 million deaths, unfortunately. And the COVID-19 pandemic across the world is showing no signs of abating or decreasing. We're still seeing an exponential rise in new cases, this thing is really not slowing down. And why should we care about this in the cancer research or cancer community in general? Well, unfortunately, patients with cancer have a disproportionately high risk for adverse clinical outcomes. Actually, meta-analysis put the mortality rate from COVID in patients with cancer at 25.6%. This is a point estimate of a pretty wide range because obviously patients with cancer are fairly heterogeneous, and we'll dig into that a bit later. But the overall message is patients with cancer are doing much worse when they do develop COVID-19. So this is the outline of my presentation for today. I'm going to touch upon 4 themes, which I think are important. One is, why are patients with cancer faring worse? I just said that the mortality rate is very high in this population of patients, and really, I think, need to understand why if we're going to tackle this problem. 2 are testing procedures and the clinical characteristics of COVID-19 patients with cancer. 3 is a cancer care delivery during the pandemic. So not only are patients with cancer disproportionately high risk for adverse outcomes when they do develop COVID-19, but also the delivery of cancer care during the pandemic has been disrupted, which may put patients at risk of worse cancer-related outcomes. And 4 is the impact on healthcare workers and scientists, in particular within the cancer research community, and what the impact of that would look like down the line, or could look like down the line. So for the first part, why are patients with cancer faring worse with COVID-19? Well, the first answer to this, I would say naively, is overlapping demographics. Patients with cancer are older generally than the general population. So, and we know that patients who are older generally fare worse with COVID-19, unfortunately. 2 are comorbidities. So, unfortunately, patients with cancer tend to have a number of non-cancer-related comorbidities, which have themselves been associated with adverse outcomes with COVID-19. Smoking is the same story. Patients with cancer are more likely to be smokers, and smokers do worse with COVID-19. And finally, male sex, which is has been associated with adverse outcomes with COVID-19. And obviously, for some cancers, men are at high risk of developing certain cancers. The second one that I'll expand more upon is overlapping biology. So patients with cancer have these overlapping demographics, which might explain part of it. But the second part, I think, is more complicated, and we can learn quite a bit more from, is the overlapping biology. Are there biological reasons beyond these this overlapping demographics that can explain why patients with cancer unfortunately do worse with COVID-19? And I'm dividing this into 3 parts, which I expand upon in the next few slides. One is the SARS-CoV-2 virus internalization. 2 are the immune interactions between the immune system and of patients with cancer, and the immune dysregulation that we see with COVID-19. And 3 is the increased risk of thrombotic events. And I'll just highlight that this, a lot of what I'm going to discuss briefly here is sort of more is expanded upon in a recent review that we've published in Cancer Cell, who I acknowledge also my co-first author on that review, Jessica Hawley. So you can take a deeper look into that after the presentation if you want to. So the first part is to understand what's happening at the internalization stage of SARS-CoV-2. It's important to get a quick sense of what the virus is made of. And I'm obviously not a virologist, and I don't know much about viruses in general, but just a very brief overview is the SARS-CoV-2 virus is an enveloped virus with a spike glycoprotein on the envelope. And that spike glycoprotein is really essential because that is what binds to the host cell receptor to allow internalization of the virus. And the structure and sort of internalization mechanism became evident pretty early on. And there's this nice cell paper that was published, I think, quite a few, more than 8 months ago now, that showed the parallelism between SARS-CoV-2 and the preceding SARS-CoV virus that was responsible for the initial SARS epidemic. And what that study showed is that there's a lot of there are many parallels between SARS-CoV-1 and SARS-CoV-2. They attach to the same receptor, ACE2. TMPRSS2 is an essential serine protease that allows the internalization of the virus for both. And that really allowed us to get a sense of, because we knew quite a bit already about SARS-CoV, we sort of extrapolated quite a bit of that to SARS-CoV-2 as well. And this is a separate, sort of a more detailed view of how the internalization process of SARS-CoV-2 happens. Obviously, SARS-CoV-2 is the virus that's responsible for COVID-19. And what this schematic is showing is part A here is SARS-CoV-2 binding to the ACE2 receptor on the host cell's membrane. Then you can see that TMPRSS2 primes the spike glycoprotein as the endocytic vesicle starts to form. And then once the endosome is fully formed, other serine proteases, namely cathepsin L, sort of plays a role to cleave that membrane, allowing the externalization of the single-stranded RNA into the cytoplasm of the cell. And that's how infection happens. So with that very brief background to the virology that underlies SARS-CoV-2 and the internalization process, how is this relevant to COVID-19, to the interaction between COVID-19 and cancer? Well, the ACE2 receptor that we talked about before increases with smoking, or at least has been shown to, its expression has been shown to increase with smoking. And this is within lung tissue or respiratory tissue in general. And since patients with cancer are more likely to be smokers, then there are a few studies that are suggesting that that may be one of the reasons why patients with cancer might be at disproportionately high risk of COVID-19 infection and adverse outcomes with COVID-19 because of this increased expression of ACE2 within the respiratory tract. The other factor is age, although that's a bit more controversial. Older age has been also associated with increased expression of ACE2 within the respiratory tract. And again, patients with cancer, unfortunately, tend to be older, and therefore that might explain a part of it. The second part of why this is relevant to cancer is TMPRSS2. Now, this is not so much about the increased risk of patients with cancer to develop adverse outcomes with COVID-19, but the opportunities that we can learn from cancer biology. So TMPRSS2 is an androgen-regulated gene that's been widely studied within the prostate cancer literature because of the TMPRSS2 ERK fusions that are very frequent in prostate cancer. TMPRSS2 is also expressed in lung tissue and is believed, again, to be key for the internalization process. So one thing that's been really hypothesized is that androgen deprivation therapies, which are widely used for the treatment of prostate cancer, could be used to downregulate TMPRSS2 within lung tissue and sort of can serve as a potential therapeutic opportunity for patients with COVID-19 in general. Not only those with cancer, but in general, patients with COVID-19 may benefit from this. And I think that's something that's important to highlight because, really here, the prostate cancer research community has been at the forefront of pushing this concept because we've, and I'm saying we because my sort of day job is a postdoc in GU oncology where this is one of my interests, where we've studied TMPRSS2 regulation, and we know that the androgen receptor regulates TMPRSS2. And there's been some clinical data to support this. I won't go into too much details, but there is some preliminary clinical data out of Italy and out of Mount Sinai in the United States, in New York, that have suggested that patients that are treated with ADT tend to do better clinically than patients that were not treated with androgen deprivation therapy. So there is some clinical support for this. The biological data, I would say the jury is still out on the preclinical relevance. The main question, I would say from a preclinical standpoint, is whether the androgen regulation of TMPRSS2 holds up in lung tissue. And I think that is still an issue of active investigation. And there are also clinical trials that are ongoing to test these therapies within a controlled setting. So this was for the internalization section. The second part was the immune interaction between SARS-CoV-2 and cancer. So unfortunately, patients with cancer are more likely to have immune suppression. There's the intrinsic immune suppression that's associated with cancer. In general, patients with cancer, due to their disease, can have can be immune suppressed, can have immune suppression due to cancer itself, or the immune suppression could be actually one of the causes of cancer. So really, immune suppression and cancer often go together. But there's also the iatrogenic causes, the therapy-induced causes, chemotherapy, other therapies that we give to patients with cancer might induce immune suppression, and that might lead patients to be at increased risk for COVID-19 infection, but also adverse outcomes of COVID-19. The second side of this coin is the opposite. Some therapies that we give to patients with cancer, particularly immunotherapies, could stimulate the immune system or do stimulate the immune system, and can increase the risk for the cytokine storm or the bradykinin storm that we see with SARS-CoV-2. So as I think many of you know, COVID-19, when patients present with severe COVID-19, they generally present with a hyperinflammatory state that looks like ARDS, where patients have sort of an increase in a bunch of different cytokines and a general pro-inflammatory state. And this pro-inflammatory state generally associated with very poor outcomes in patients with COVID-19. So really the question here is, when we give these therapies, so immune checkpoint inhibitors, CAR T cells, TILs, et cetera, to patients with cancer, will they be at increased risk because of this immune stimulation with these immune therapies? Would these patients, if they're infected with COVID-19, be at increased risk for adverse outcomes? I think so far we don't have definitive evidence as to whether that is the case. There's certainly a preclinical rationality for why that may be the case, but I'll expand a bit more later on the clinical data of why we're still a bit uncertain on that front. But one thing I would like to highlight is that we've been sort of trying to use what we've learned from the cytokine release syndrome that we know well from with CAR T cell therapies and other therapies, and that is frequently treated with things like corticosteroids, IL-6 receptor inhibitors, and those are being tried now for the treatment of this cytokine storm of COVID-19. So that is a second sort of therapeutic opportunity where the cancer research community has provided the preclinical evidence or even the clinical experience in this case that would support sort of a rollout of a potential therapeutic opportunity for patients with COVID-19 in general. And IL-6 receptor inhibitors, there's been a few retrospective series now that have shown potential benefit. There is some randomized clinical trial data that seems to be negative, although I believe we still don't have the data published. There's a few press releases to suggest that though the IL-6 receptor inhibitors are not effective for COVID-19 in general, again, this is not specifically for patients with cancer, but this is still an area of active investigation and sort of a second potential avenue where the cancer research community can teach something to, or can provide a therapeutic opportunity for the wider treatment of patients with COVID-19. The third biological interaction I'd like to highlight is at the level of thrombosis. So, and this is for both arterial and venous thromboses. So COVID-19, so COVID-19 is associated with a high rate of symptomatic thrombotic events in general. And this is just in the general patient population, not specifically patients with cancer. The rate of symptomatic thrombotic events has ranged between 9 and 21%. One study that did systematic duplex ultrasonography for patients found that up to all of them could have, especially those that are not on any sort of anticoagulation, could have an underlying thrombotic event, especially a venous thrombotic event. And this may be related to the immune activation that we see with COVID-19, or due to an endothelial cell infection. That is something that's been documented within lung tissue in particular, where the endothelial cells have been shown to sort of have a direct infection by SARS-CoV-2 and in endotheliitis, so infection of the endothelial cells. In cancer, unfortunately, we also have a baseline procreative state. So in general, patients with cancer are more likely to develop VTEs in particular compared to the general population. And this may be further increased by certain therapies, surgery, or other therapies for patients with cancer can further increase this risk. So there's certainly a perceived risk for increased risk for patients with cancer who develop COVID-19 to have to have an increased risk of developing thrombotic events, although the clinical evidence is still not there. There's still not sort of strong clinical data to suggest that this is the case, but there's certainly, again, a very strong preclinical rationality. And it also might be the case that a lot of the adverse outcomes that we're seeing in patients with cancer might be to sort of these thrombotic events, although this has been not, again, though documented, not, I would say, conclusively shown that this is the reason for this is one of the reasons for the adverse outcomes of patients with cancer who develop COVID-19. Okay, so I went through the first part, which was why, sort of the biological interactions and why patients with cancer might be doing worse with COVID-19. The second part I'd like to expand upon is sort of the clinical characteristics and the testing procedures for COVID-19 in patients with cancer. So COVID-19 testing, and this is just mainly recapitulating ASCO guidelines with some editorialization. I've divided this into, and I would say these are pretty straightforward and common sense guidelines. So what tests should we be doing? I think generally just the RT-PCR standard test with based on a nasopharyngeal swab for the viral RNA, was maybe antigen testing and or antibody testing as needed, although in most cases, say an RT-PCR viral RNA using a nasopharyngeal swab is what's considered to be the standard. So this WHO question, I would say everyone, if you have the resources and if you have the capacity to test frequently, test as much as you can. But in general, and especially during peaks of the pandemic, like we've seen in the United States, unfortunately, prioritization is often in order. So especially during peaks, I think it's important to prioritize. And the priority list would go from patients who are within the inpatient setting and who are symptomatic, because these are the patients that are most at risk for adverse events. 2 would be patients within the outpatient setting and who are symptomatic for COVID-19. And 3 would be asymptomatic patients with cancer or presenting to your clinic and are planned to start some sort of immune suppressive therapy, generally any anti-cancer therapy, to be frank. You can consider testing, but that would be the lowest priority if you need to prioritize. So if they're symptomatic, it's pretty easy as soon as they present. If they're asymptomatic, a general rule of thumb would be to test 48 to 72 hours so you get the results before the planned start of an immune suppressive therapy or an anti-cancer therapy. So we've talked about testing. What are the clinical characteristics of COVID-19 in patients with cancer? This is a very nice chart from Cell, just showing what these general symptoms are for patients with COVID-19 in general. And they include things I think that we know very well at this point: fever, dry cough, fatigue, sputum production, diarrhea, myalgia, arthralgia, etc. And these we know well, and they're generally the same in patients with cancer. There's really not much of a difference in terms of the clinical characteristics of patients with cancer who develop COVID-19 versus the general population, except that's it's just worse. Patients with cancer have the same symptoms, but they're just probably more frequent and worse, and they could present earlier within the disease course. Okay, so I think we generally said that patients with cancer have similar presentations to the general population, but also we're sort of lumping all patients with cancer together. We're saying all patients with cancer are at risk for COVID-19, but that's not really true because this is a fairly large population of patients with a generally diverse set of risk factors and a diverse disease course. So there, I'm highlighting here a summary table from actually our review article in Cancer Cell that I mentioned earlier, that sort of tried to summarize the large number of studies now that have looked at the outcomes of patients with cancer who develop COVID-19 and tried to ask the question, can we determine the prognostic factors in patients with cancer who develop COVID-19? I think that's important because this patient population is heterogeneous, understanding which patients are at the highest risk of developing adverse outcomes is a priority to be able to consider the risks of COVID-19 in specific patient populations. So this summary table again summarizes the largest studies to date. One is the CCC19 study. This is a consortium that's international but mainly US based that I'm very fortunate to be part of. The UK CCMP study, which is a UK multi-center study on COVID from Europe, TerraVault, International. The first three were included all patients with cancer. TerraVault included only lung cancer patients. The Albiges et al. Study in Nature Cancer is a French study just from a single center from Gustave Roussy, including all patients with cancer. Another study here, Rabiletti et al. From MSKCC in the United States, and a few other smaller studies from China and Italy. The Italian one was just patients with hematological cancers. As you can see, the number of patients ranged from roughly 105 patients to around 1,000 patients with cancer who develop COVID-19. And what all of these studies largely asked are which patients within this diverse set of patients with cancer who develop COVID-19, which patients are at the highest risk of developing adverse outcomes. And a few key themes popped out that aren't entirely consistent across the different studies, but I'd say there are consistent themes from these different studies that are differentially powered to detect roughly the similar effect sizes and have slightly different designs and inclusion criteria, which so it's hard to directly compare, but overall the themes I think are consistent. And the themes are that patients with lung cancer and hematological cancers appear to be doing worse. And this is consistent across a few different studies, as you can see illustrated here. And then not only is the type of cancer relevant, but also the status of the individual cancer. So patients that have active malignancies, and that is generally defined as just cancer that is not in remission, or in some cases defined as being metastatic versus non-metastatic cancer. So these patients are generally at risk for adverse outcomes with COVID-19. And then another one that's a bit more controversial and a bit hard to sort of tease out is systemic therapy. I think systemic therapy is particularly hard to tease out for a few reasons. But I would say one is that systemic therapy is obviously very diverse. Patients could be receiving chemotherapy, immune checkpoint inhibitors, but also in addition to the differences in type of systemic therapies, there's a difference of when the systemic therapy was received relative to the onset of COVID-19. I'd say there are now a few conflicting studies with this space. So it's really, the jury, I would say, is still out on specific signals as to whether chemotherapy, I would say, 4 weeks before the onset of COVID-19 or 6 weeks could be a risk factor for adverse outcomes. But I think generally speaking, it's considered that patients who are on immune suppressive therapies just before the onset of COVID-19, from a preclinical perspective and just from a rationality perspective, will be expected to have adverse outcomes. But the clinical signals themselves, because of this heterogeneity and because of the presence of confounding factors, this has not been conclusively been shown. For immune checkpoint inhibitors, as I mentioned before, because of the rationality of this might be inducing a cytokine storm, there's sort of a bit of risk that these patients will be at risk for adverse outcomes. But again, this has been shown in a few studies, but not consistently across the different studies. So we talked about type of cancer, lung and hematological cancers, the tumor status, the systemic therapy, and the final one, which I think is a very important one, is the general factors. And these are factors that have been shown now consistently across a number of studies within the general population to associate with adverse outcomes in patients with COVID-19, such as increasing age, male sex, comorbidities such as cardiac or pulmonary comorbidities, performance status, and so generally the general state of the patient, and smoking have all been found in general population to associate with adverse outcomes. And across these different cancer patient specific studies have also been found pretty uniformly to associate with adverse outcomes in patients. So what do we take out from this heterogeneous pool of studies I've just presented and this sort of a bit of a dizzying table? What are the take-home messages that we can take out from this literature review? Well, we could sort of divide the clinical prognostic factors for clinical outcomes of patients with cancer into 4 buckets. Tumor characteristics, again, lung and heme malignancies tend to associate with adverse outcomes, and progressive or active disease, receipt of systemic therapy, systemic anti-cancer therapy. It's sort of mixed data. I would say generally the overall message should be that, and I'll expand upon this a bit later, is that patients with cancer do need these systemic therapies in many cases, and when they do need them, I think the risks of delaying therapy can outweigh the risks of, especially if you're not in a stage of really a very active pandemic, can outweigh the risk of COVID-19 induced adverse outcomes in these patients. So generally, I would say the message should be systemic therapy is generally safe in the midst of the pandemic and should be continued. And I'll discuss this in a bit. General factors, I think these are the most consistent, the most important probably, along with the tumor characteristics. So age, male sex, etc., which associate with adverse outcomes. Oh, sorry. And the final one, I think, is an important one, especially in the US, where there's a lot of diversity in socio-demographic factors between different geographic areas, but also within similar geographic areas. What we've seen is the social determinants of health playing a key role in sort of a prognostic, in terms of prognostic factors. This has been reported within the general population, but we're also seeing hints of this now within the within patients with cancer. In particular, one study that I was very fortunate to be part of as part of CCC19 reported that Black patients in the United States, in particular, tended to be less likely to receive remdesivir, which has been shown to improve outcomes of patients with COVID-19. And more recently, in a Cancer Cell paper that was actually just published a few days ago, that was very fortunate to co-lead with Andrew Schmidt and Sheena and others, as part of the Cancer and COVID-19 outcome study, a multi-center study from the Northeast of the United States. We found that patients that are part of socio-demographic minorities, so especially Black and Hispanic patients in the United States, tended to be less likely to benefit from telemedicine in particular, and tended also to be more at risk of developing COVID-19. This was in patients with cancer specifically. So we do see these hints of the social determinants of health playing out in patients with cancer as well. So I sort of talked to you quite a bit now about the clinical prognostic factors in patients with cancer who develop COVID-19, but I don't want you to take my word for it. What we've recently built, and we've actually just published this very recently, we built our Shiny app on our website, and you can see the website here, where you can actually take our patient level data from the cancer discovery paper that I just mentioned and explore the prognostic factors in patients with cancer who develop COVID-19. And this is an interactive app, and you can explore the data for yourself. A lot of the sort of these explorations we did not report on in our paper. So we've made this data publicly available and interactively available on our website so that you can explore the data for yourself and sort of glean new insights as to what might be driving prognostic, the adverse outcomes in patients with cancer without COVID-19. I should say that these are unadjusted estimates, so you can only look at 1 or 2 variables, and you can't really build models. But I think it can provide you with preliminary insights into what may be driving adverse outcomes in patients with cancer without COVID-19. Okay, so we talked about the clinical prognostic factors. The next question was, are there biomarkers? Can we determine biomarkers for adverse outcomes in patients with cancer that would sort of supplement the clinical factors we just talked about? And I think we're starting to get a few biomarkers. One that I've previously alluded to are the inflammation markers. As I've said before, patients that develop a cytokine storm, in general, with patients with COVID-19 who develop a cytokine storm, tend to have adverse outcomes. And what we're seeing is that when patients with cancer, who generally can have sort of baseline pro-inflammatory state, especially of the innate immune system, but also when they are treated with immune therapies, as we previously said, can have an increase in certain inflammatory markers like IL-6, TNF-alpha, CRP, procalcitonin, etc. And these inflammatory markers have been associated now in two independent studies that are in patients with cancer with adverse outcomes in patients with cancer who develop COVID-19. So inflammatory markers could be one biomarker of adverse outcomes. Another one is markers of organ damage. Again, this is from two separate studies. Decreased albumin, baseline decreased albumin, and an increase in cardiac enzyme and LDH, especially after the patients develop COVID-19, can be early biomarkers of adverse outcomes in these patient populations. Again, this was within patients with cancer who develop COVID-19. And finally, markers of immune dysfunction. So the extent of decrease in lymphocytes. So we know that COVID-19 does associate with lymphopenia, but also the extent of decrease in lymphocytes can associate with adverse outcomes, as well as the level of monocytes and CD4 positive T cells. And finally, and this is from a recent cancer cell study, actually a very interesting study in both the general population and specifically in patients with cancer, what was found is that the baseline viral load associates with adverse outcomes. So patients with cancer with a baseline higher viral load tend to have worse outcomes. And this is consistent across the general population and patients with cancer, as you can see from this very nice graphical abstract here. Okay, so we've talked about the clinical prognostic factors, the biomarkers, as well as the testing procedures and clinical characteristics of patients with cancer who develop COVID-19. But the next question is, how has cancer care delivery itself been affected during the pandemic? And this is not for patients with cancer who develop COVID-19, but in general, patients with cancer, irrespective of whether they develop COVID-19 or not. And I was probably in Australia and in Melbourne, you haven't felt the brute force of this, but in the United States, I think there were some very hard discussions about should we still be administering anti-cancer therapy for patients with cancer, and what should we prioritize, especially at the peak of the pandemic when when resources were limited, but also we were afraid that patients with cancer who might come in for their therapy, especially if they're IV therapies, et cetera, or surgery or others, could we be putting them at risk for COVID-19, especially given their risk for adverse outcomes when they do develop the disease? So some very helpful guiding principles that we sort of saw emerge pretty early on in the pandemic as to how to think about this are considering two groups of factors. One is, what is the context of therapy for these patients, and what is the context of the pandemic? So in terms of the context of therapy is, why are we giving that therapy to that patient? Is it a therapy of curative potential? Is this in the setting of potentially curative therapy instead of acute leukemia or high-grade lymphoma or testicular cancer, for instance? In that case, whatever the context of the pandemic, you should really try to prioritize that therapy, and I think that's common sense. You shouldn't delay that therapy. I would say in a more nuanced situation is if this is some sort of therapy that is of moderate clinical importance. So this is some therapy that is associated with an improved overall survival, benefit that's thought to be substantial. I'll give you an example from kidney cancer because I know that well. So this is the axitinib pembrolizumab setting, the first line treatment of metastatic RCC. Definitely want to try to give that therapy. We know that that therapy will help that patient. So we definitely want to try to give that therapy to that patient. And we can adapt the protocol maybe in certain instances, and this really depends on the specific protocol, the specific setting, to sort of decrease healthcare utilization, for instance. But you still want to do your best to give that therapy to that patient and try to minimize delay. So 1, no delay; 2, minimize delay, and maybe adapt on a case-by-case basis. 3 is the marginal impact on quality or quantity of life. So this is typically the situation where a patient is sort of in the later lines of systemic therapy, where there's not really an established overall survival benefit. And I'll talk about the context of the pandemic, but especially if you're in the peak of the pandemic and you might be exposing that patient to a risk of contracting COVID-19 for a marginal effect on overall survival or on quality of life, you probably want to delay the initiation of that therapy. And the final one is survivorship and surveillance. If this is just for surveillance, just conduct remotely as much as possible. Get your patient, don't make your patient travel a lot. Try to get them to get their scans somewhere where it's close to them. If they don't need to come into clinic, don't have them come into clinic, et cetera, et cetera. And then beyond the context of therapy, the next sort of important factor is what's the context of the pandemic. So number of cases. One is, are we in a peak phase of the pandemic or a non-peak phase? This is a peak phase, and in a high peak like we saw in the New England area of the United States, for instance, in Boston or New York, that is a significant consideration. 2 is, and relatedly to the peak versus non-peak factors, what are the available resources? Do you have enough PPE? Do you have enough hospital beds? Do you have enough healthcare workers to tend to these patients? Are your oncologists all on COVID-19 wards? Are they all quarantining because they've been exposed or infected? These are all factors that will factor into your prioritization. Again, not for the curative therapies, but maybe for something a bit less urgent. And the third case is telemedicine resources. It's all fine and interesting to talk about you wanting to provide telehealth services to your patients, but that assumes that your patients have access to that. And as I just discussed before, and as we've recently highlighted in our Cancer Cell paper within the COVID-19 cancer outcomes study that was just published, we are seeing that minorities, for instance, in the United States, are really at increased risk of not being able to benefit from those telehealth services. So you really need to be, I think, mindful of what resources are available to your patient populations and tailor that to the specific patient that you're seeing in clinic. And so these are some very nice guiding principles, but can we dig deeper? I think one try at digging deeper at this is this on-COVID model, which is a very impressive paper that was just published in JAMA Oncology very recently, I think a few days ago or a few weeks ago at best. What this study tried to do is to sort of factor what we just talked about now. What is the perceived benefit of that specific therapy? What is your caseload right now? And what is the risk of delaying that specific therapy? And they sort of tried to factor all of that in, let's say, very nicely into a comprehensive model. And I've put the link here for the actual model that you can access. You can sort of plug and play and change the parameters and estimate for your specific patient what the risk of delaying therapy would be. I think this is a very nice and the most comprehensive approach I've seen to sort of address this question quantitatively. My rough take on this is that although this is a very nice study and very nicely done, I don't think you can directly plug in your numbers and think about this. I think this really needs to be individualized to every single patient. Though maybe this could be informative, I think it really comes down to your discussions with your patients, how you prioritize your care, and what are your perceived risk within really your specific area, and how you can tailor that to your specific patient and their specific risk of COVID, but also their cancer. Okay, so we've talked about cancer care delivery for patients that already have their cancer diagnosed. But another concerning trend that I'd like to highlight, and I would say this has been underreported on, is the decrease in cancer screening. And there's this very nice paper in JCO-CCI that has reported upon this sort of fairly early on. What that study has shown very nicely is that there's a substantial decrease in cancer screening rates, This is data primarily from the United States. I think entirely from the United States, actually, showing that mammograms and colorectal exams have sort of decreased as you'd expect during the first peak of the pandemic, at least in some areas in the United States, we see a very pronounced decrease in cancer screening. And this has been accompanied by a decrease in new incidence patient counters for various cancers, such as lung, breast, prostate, colorectal, heme, and other cancers. So this is concerning because obviously we don't expect that during the pandemic, the incidence of cancer will decrease, but we're sort of detecting less cancer. So how that will affect patients later on and whether they will have a missed cancer diagnosis and later present with more advanced disease is something that appears likely, is fairly certain will happen. So I think this is important to highlight because obviously we're seeing different rates and different timings for the peaks of the pandemic, but I think it's important to sort of hammer home the message that we shouldn't keep this trend of decreasing cancer screening, especially cancer screenings that have been shown to have a substantial benefit for patients. We should resume these as soon as possible to not miss cancer diagnoses. The final point I'd like to highlight, and this is something that I think since we as healthcare workers and as doctors and as researchers sort of are generally, I would say, and this is a very nice factor, are generally fairly altruistic. We think about everybody except ourselves. So this last point is sort of hitting closer to home and trying to think about what's the impact on healthcare workers and on scientists. This is also a graphic from our review and sort of trying to summarize the myriad of factors that are affecting healthcare workers and cancer researchers, such as I think most of us or all of us. One is the personal stress, and this is not maybe unique, but actually maybe a bit unique to physicians, especially those on the front lines, who have concerns for PPE, especially in areas of, and we saw this in certain areas of the United States, lack of PPE, and also concerns for your family members. If you get COVID, will they be at risk? If you have someone who's, for instance, elderly or at risk at home, that is certainly a concern. The second one is how do you care for your patients? And hopefully, at least this presentation was partly, at least a bit helpful in sort of guiding that for patients with cancer, when to test, how to deal with that. And I think that is an added stress of how do you take care of your patients. 3 and 4, I would say, is research and funding. So in the United States, I can tell you our experience at Dana-Farber is we had a lockdown of our labs, or our wet labs in particular. So I work mainly in a dry lab, but for my colleagues in the wet lab, there was some very serious effect on their research for my wet lab colleagues, and that I think is going to have a substantial effect on the medium to even long term, because these labs had to close, and this might be affecting certain populations of researchers, especially early career researchers who sort of rely on their first studies to be able to maintain continuous funding. This is a particular problem in the United States, and their timelines have been delayed. There has been some understanding in terms of funding, and there have been some sort of extensions, but not with funding extensions, just with delay extensions. And this has been now highlighted by a few different societies, and we've highlighted this in our review, and we actually spoke to the leadership of the American Cancer Society, who also highlighted the steps that they are taking to sort of address that. But the problem is that philanthropic funding in particular has been decreasing. So donations, which are a big factor in a lot of the research funding, at least in the United States, I think this is also the case in Australia and Canada and a few other countries where and in the UK actually, where philanthropic funding plays an important role in funding researchers, and maybe even more so early career researchers who rely on this funding. This funding has decreased. With the decreased productivity, this might have not only an impact on research right now, but the future of cancer research and the future, therefore, of cancer care. And it is possible, if we don't address this on the long term with government policies and other such policies, that this might lead to sort of a lost generation of cancer researchers if not more mindful of this risk, especially for my wet lab colleagues. Okay, so I've hopefully not bored you with my presentation today. I would like, before we conclude the presentation and go to Q&A, which I look forward to, acknowledge my colleagues and my mentors. So especially Jeremy Warner, who's the overall PI of the COVID-19 and Cancer Consortium. Again, this is a consortium of more than 125 institutions, mainly in the United States, but across the world, actually. Tony Schwery, the PI of the COVID-19 Cancer Consortium study at Dana-Farber Cancer Institute, and one of my primary mentors at Dana-Farber, also the head of the Lang Center for Gene Oncology. Andrew Schmidt, who is a postdoctoral research fellow and a medical oncologist who works with me at Dana-Farber and who sort of spearheads with me the COVID-19 and Cancer Consortium's local effort at Dana-Farber and the Dana-Farber Harvard Cancer Center, as well as the COVID-19 Cancer Outcome Study. And he's a sort of a born and bred Australian from North Queensland. He tried to prep me to have an Aussie accent, but I think he failed miserably given how my performance is going. And I put this squarely on him and not on me. Jessica Hawley, the co-first author on the Cancer Cell Review I mentioned, Corey Painter, Solange Peters, Brian Reaney, Deb Dorishaw, Sheena, and Matthew, who are our co-leads within the COVID-19 Cancer Outcome Study that I highlighted and who are based at Mount Sinai. Just generally the awesome cancer research community that has come together to sort of try to answer these important questions that I think, clinically relevant questions that I've tried to summarize within this presentation. And thank you all very much for listening to me. And I encourage you to visit our COVID-19 Cancer Consortium website, and I provide the link below, and also tweet at me. This is my Twitter handle. I'll be happy to respond to your questions there as well, in addition to during this Q&A session. Thank you all very much.
Thank you, Ziad, for a phenomenal presentation. Absolutely superb. I know I'm much more knowledgeable now than before. Very well set out and clear. I thought it was fantastic. Good to see Andrew there. Andrew did some of his training in Melbourne, so we know him well. Just to remind us that even despite COVID, our borders were only kind of a video away. So hello, mate. Good to see that he's leading the fight in the US. So we've got some questions. Can you see them, Ziad? So the first question: defining the interaction between COVID outcomes and systemic therapy has been challenging, as you've highlighted. Do you have any advice on better ways to study this if we see higher rates in Australia once again?
Yeah, I think that's a very interesting question. So our approach to studying this has been, and I really want to give a shout out to Jeremy Warner here, as the PI of the COVID-19 and Cancer Consortium. So what we've tried to do there is we've organized very quickly to be able to address this question. I think it's been pretty altruistic of everyone, of all the institutions, because I think we all quickly realized that this is sort of an avalanche, and we're seeing these patients having adverse outcomes. And especially initially, we had no idea how to collectively, as a community, deal with this. What do we do? How do we treat this? So I think this brought on the best in everyone. And we saw these different consortia pop up in the UK, United States, and Europe. And I think that has been the right way to go about it. Organize quickly, have a common database, understand. So a lot of what we've been benefited from in the CCC19 consortium has been informatics sort of feedback and input. And we've been able to get a sense of what can we pull automatically, what do we need to curate manually, how do we organize our database set in an efficient manner to ask the important question, prioritization of variables to collect, prioritization of what your inclusion criteria should look like, what do you want to specifically study. We sort of defined that fairly quickly within the CCC19, got a head start, and then we didn't get it perfectly. I can tell you that we've been editing the questions and so the variables we've been collecting along the way. And we started off with our first report, which was on 900 patients. Now we're at, I think, around 5,000 patients or more, 6,000 patients, where we have collected some very granular data. and high quality data where we're able to dynamically ask questions and change the database and the variable structure as we go along. I hope that's helpful.
Yeah, definitely. Someone's asked, can Australian sites contribute to your data, to the CC19 data?
I think, so we have if you go to that CCC19 website,
yeah.
We have a sort of a link and somewhere where you can contact us and to contribute your data. We have lawyers involved because there are DTA issues and data transfer agreements. I know that we've been
There's
able
always
to
lawyers involved.
Exactly. So I won't even start to pretend to understand that part, but what I will say is that we have some very dynamic lawyers that are involved and have been resolving these issues. I know that we've resolved them for sites in Canada and across multiple countries in South America and Europe. So it's not impossible. Get in touch and we'll figure it out.
Yeah, excellent. I think we're going to explore that. I'll hold you to that one. That's excellent. Is there a correlation between severity of presentation and biomarkers of severity? Could they be a surrogate for delayed presentation?
That's a very good question. So I think that is a very hard question to tease out because it's often very hard to know when you're seeing your patient in clinic or in the emergency department, when did that patient actually contract the infection? So it's very hard to tease out. I think we unfortunately only often get the snapshot of these biomarkers, if any biomarkers. We are trying to explore this question of how the dynamic change, how that changes dynamically. So one way to address this question, I think, is if we get multiple time points during the course, if we see a patient sort of in the inpatient setting, can we follow that dynamically and see how much shift we see within these patients and how that change during their course affects the overall or the final outcome? So I think the jury's still out on that, but I think it's a very interesting question.
And I've got a question as MC, I've got that discretion. There's lots of evidence about the mortality of COVID and cancer patients. What about the morbidity and the impact on their survival, as in unable to get further treatments and therefore inability to have second line or third line, etc., fourth line treatment, and their quality of life being post-COVID. We know that in healthy patients, some people are having significant survivorship issues. Has that been studied in the post-COVID cancer patient?
I think that's a very interesting question that we're starting to try to tease out within the COVID-19 Cancer Consortium. So far, the data I've shown you has been mostly 30-day mortality. We're starting to look at longer-term outcomes. Again, as I've said, initially, how this came about is we're seeing patients and we didn't have I would say, the luxury of thinking very long-term. We just wanted to prioritize some things that are very simple. What sort of anti-cancer therapy should we be giving, and which patients are at most risk of developing adverse outcomes, and can we sort of do something about it very quickly? That was our first reflex, which I think is normal. And now that we've sort of learned more about the disease, we're starting to ask these questions, thinking about longer-term outcomes. I don't think we know much really about the long-term morbidities then, and I think it's a very, even within patients without cancer, I think it's still an open question because we just don't have enough follow-up yet, and even less so within patients with cancer. So very interesting question, but unfortunately we know very little.
In Melbourne, we've been quite lucky, even though we've had a significant second wave, the amount of cancer patients who actually had COVID-19 has been remarkably low. I know for a fact, I'm a busy oncologist, I've had zero. So I've got no experience in that aspect. I'm very fortunate, got to touch wood. But I think we'll be looking at obviously in the US and the UK on data and guidance on this point. So this now really comes to the end of our presentation. I'd like to thank Dr. Ziad Bakouny for an amazing presentation. I thoroughly enjoyed it, and I'm sure all our attendees did. And I'll be encouraging all our trainees, our registrars and other consultants really to review the presentation. I'll probably be recording it in our unit meeting. It was excellent, mate. I really enjoyed it. So this brings an end to today's Cancer and COVID-19 seminar. Thank you for everyone involved in the presentation and the audience for tuning in. If you're a healthcare professional who's not part of the VCCN, please join. The more people involved, the better. Our collaboration is the key to all things good. And if you're a patient or carer and you have questions about COVID-19, please contact the Cancer Council Victoria. They're excellent for information, and a support hotline 131120. Everyone take care, keep safe, and hopefully we can meet face to face once again in the future.
I'd like to visit Melbourne. Thank you all so much. Thank you so much, Phil. It was a pleasure speaking to all of you.
Okay, take care. Bye.